New Mexican. It's a very rural area. And I did my medical school training at Albuquerque, New Mexico, which is where the only level one trauma center is there in the whole New Mexico. And coming from a pretty rural place, I actually was an EMT as well. So I've always wanted to get more involved with EMS after being a trauma surgeon. So I'm hoping that we can get our trauma department more involved as well with for their presentations, maybe even hopefully show up with some hands-on skill sessions or whatever that Dr. Bach would like us to do with you guys. So thank you guys again for the opportunity for this presentation. So we're going to talk about today about traumatic brain injury. And here's a brief overview of what it's going to be like. We'll start off with some case presentations, talk about the pathophysiology of brain injuries, the pre-hospital assessment and management of the brain injuries, some adjunctive treatments, and then just a little review, okay? So when we go over the cases, I'm going to present the case, show some imaging, and I'm going to hold off on the outcomes and what we did for the stuff and focus a little bit more on the pre-hospital things, okay? And this is going to be, I'm going to try to make it a little interactive, so I will ask some questions. Those of you who want to answer, more than welcome to, but if it's going to be kind of silent for a couple of seconds, then I'll probably just talk. All right, let's start with the first one. The first case, and these are all real cases, by the way, so some of you may have actually been on these runs, so you can see the outcome of the patients. So here's a 32-year-old female, history of bipolar disorder, fetal alcohol syndrome, who fell in jail after passing out, and she had a scalp laceration. Per the jail, the patient has been passing out quite a bit recently. She, I believe, was on a top bunk, but she was found on the ground. Upon arrival with EMS, the blood pressure is 120/70, pulse 126, SpO2 at 98% en route air. During ground transport, the GCS was 13. There was no end-tidal CO2 recorded. The patient was alert and talking to EMS. However, during that transport to the hospital, she began crying, and then she had an episode of emesis. By the time she arrived in the emergency department, she became unresponsive, began posturing, and it was noted to have uneven pupils. The ER physician there intubated her and took her to the CT scanner. And this is the head CT. So, can anyone tell me where the bleed is? Is it on the left side of the picture or the right side of the picture? All right, so it's going to be on the left side. I don't know if you guys can see my mouse or not, but you see this dark gray, kind of lighter gray. This is normal brain tissue. And this kind of really light color, that is blood. That's acute blood. And see the shape of this is kind of like a crescent. That's what we call a subdural hematoma. It's a pretty big size. That's at least, I would say, 1 to 1.5 centimeters just looking at it. And as you can see, it's pushing on the brain right over here. And here's our second case. This is a 50-year-old male who was found down next to a ladder. So it was assumed that the patient fell from a ladder. He was seizing on scene. First set of vitals, blood pressure is 193/123, pulse 95, pulse ox 99%, end-tidal CO2 was 26, GCS was 5. He was intubated on scene with an 8O tube, and the repeat end-tidal CO2 was 35. Patient received Versed and fentanyl, and the repeat systolic blood pressure was 160. When he arrived at the hospital, his GCS was 6. And here is the CT of the patient. And as we can see, he's got, right, doesn't look normal. This is normal brain tissue here, but you have all this really light, dense white color. That's all acute blood once again. So you notice that this bleed on the bottom here, whoops, sorry, it looks a little bit different than the other one we showed, right? This is called an epidural hematoma. And you see these white kind of fluid-looking things going in between the crevices of the brain. That's called a subarachnoid hematoma. And he has subarachnoid over on the patient's left side, also on the front. and he hit his head on the back. So likely he fell, hit his head, and got a counter coup injury. And here is a reconstruction of his skull and big crack on his skull. So he has a skull fracture there. All right, last case. This is a 20-year-old female who was in a high-speed MVC, hit a tree, the car caught on fire, she was not restrained, and she was ejected and found 60 feet away from the car. Initial vitals, blood pressure 132/71, pulse 80, SpO2 100% on oxymask. Her GCS was low, she vomited, so the patient was intubated on scene for airway protection. End-tidal CO2 after intubation was 41. The patient's pupils were equal and round. She arrived in the ED, vitals were stable, and taken to the CT scanner. And here's the patient's head CT. And once again, we see on the patient's right side this time, we have a subdural hematoma. But what else is, this is not as big as the first patient's, right? But also kind of worryingly, you see these right here, looks like a butterfly. That's what it's called the lateral ventricles in the brain. So this is where cerebrospinal fluid kind of lives and it recirculates. And these should be right in the middle. So you should have a butterfly shape here and a butterfly shape right here, one on each side. But as you can see, they're being pushed to the other side. So there's definitely some pressure on the brain. And we'll talk about why that's important in a little bit. All right. So that's our three cases. So quick introduction, traumatic brain injury is one of the leading causes of mortality and morbidity in the United States. Every 15 seconds, someone gets a traumatic brain injury. There's about 1.7 million people that suffer a TBI every single year. And in 2021, there were over 69,000 TBI-related deaths, which equates to 190 TBI-related deaths per day. It's very expensive as well. In 2016, the overall healthcare spending attributable to non-fatal TBI was more than $40.6 billion. And this occurs more than any other disease, affects all age groups and both genders. So it's an equal opportunity disease. So what is a traumatic brain injury? It's defined as an impact, penetration, or rapid movement of the brain within the skull that results in an altered mental state. And there's two ways you can get it, right? There is impact, where something hits the head, and there's non-impact, like blast waves, rapid acceleration, deceleration. Um, I think last summer, I had a patient. She was at a Slipknot concert, and I think she was in her 40s or 50s, and she was just headbanging. Didn't hit her head. She came in the hospital a few days later with a headache, a really bad headache. Scanned her head, and she actually had a pretty decent sized subdural hemorrhage. And we were like, "Are you sure you didn't hit your head on anything? Did you maybe drink?" And she goes, "I drank, but I didn't fall. I promise. I was with my friend. I didn't fall, but I was really headbanging a lot." So yeah, so headbanging apparently can also cause TBI. So definitely be careful for those of you who headbang a little bit too hard at Slipknot concerts. So what populations are at risk? Well, older adults are definitely at risk, and we can probably assume why. A lot of them are on blood thinners. They don't have the best balance. Their mobility is definitely impaired as well as they get older. And ages 75 and older adults have the highest numbers and rates of TBI-related hospitalizations. This accounts for almost a third of TBI-related hospitalizations and 28% of TBI-related deaths. The other is racial and ethnic minorities. It's been shown that American Indian and Alaska Natives have higher rates of TBI-related hospitalizations and deaths due to higher rates of MVCs, substance abuse, suicide, difficulties in accessing appropriate health care, as well as less likely to receive follow-up care and rehab following TBI. I grew up, like I said, in New Mexico, and in college, I had the opportunity to have some friends who lived in the Navajo reservations. And I will tell you that the reservations are big, but there's also not much healthcare in that area. And not just that, the the population there, they were quite distrusting of the healthcare entity as well. So definitely, I remember a friend of mine, her family members were pretty ill, and I say, "Hey, you guys should go to the hospital." And they look at me and said, "That's where we go to die. We're not going to the hospital." So that definitely can complicate how these TBIs are managed for them. Military service, our veterans, our soldiers, they can suffer from PTSD, difficulty accessing mental health services, and ongoing symptoms from likely whatever traumatic brain injuries they may have encountered in battle. Remember earlier I said there's non-impact TBI from blast waves, so those IEDs, explosions, mortars going off, it can affect the brain as well. Correctional facilities, right? We had a patient, the first case from a correctional facilities. There are some studies that are showing that almost half of the population in detention centers have a history of traumatic brain injury, and not all of them are screened. Homeless population, they're 2 to 4 times more likely to have a history of TBI and up to 10 times more likely to have a history of moderate or severe TBI and tend to have overall worse physical and mental health and are likely to report experiencing violence and trauma during childhood, substance abuse, and suicide thoughts. Intimate partner violence. These are also likely to be diagnosed with PTSD, insomnia, and depression. In the rural patients, they're just less likely to receive TBI care, inpatient services, and outpatient follow-up. So what are some leading causes of TBI? Falls, MVCs, traffic-related accidents, assault, sports, and recreational activities. So TBI severity, it's based on the GCS score. Um, Mild TBI, GCS 13 to 15. Moderate is defined as GCS 9 to 12, and severe is defined as GCS less than 9. The symptoms of mild TBI can include headache, nausea, dizziness, amnesia, and it may resolve in days or even weeks. Moderate severe TBI or even repeat mild TBI may be associated with increased risk of Alzheimer's disease, chronic traumatic encephalopathy, and Parkinson's disease. And one of our PAs, she always gives this really good spiel to patients with any sort of TBI, but especially mild TBI. She says, listen, if you have a TBI, and then you have another TBI within the first 3 months, it's not 1 + 1 = 2, it's 1 + 1 = 4, meaning that it is exponentially worse to have a repeat TBI within the first 3 months after a first TBI. So going into a little basic science here. So what happens when the brain gets injured, right? We saw the blood, yeah, okay, it bleeds. I understand that, but what goes on in the cellular level? Well, when the brain gets injured with any sort of trauma, there is going to be an abnormal release of potassium and calcium, and it causes the cascade of events that disrupts normal cell function. So, number one is the change in glucose metabolism. Glucose, which is sugar, is the primary fuel source of the brain. They love sugar, that's what they want. They don't really care for ketones or anything else, or fats or anything like that. So initially, what they found is that there's an increase in glucose metabolism, then followed by a decrease in glucose metabolism. They postulate that the initial rise is to fix cellular derangements. The brain's like, oh, we're injured. We better do what we can, use all the energy we can to have right now to fix whatever's going on. But then as time goes on, the glucose use is decreased due to impaired blood flow to the brain, impaired glucose transport from the blood to the brain, and abnormal glucose metabolism in the cell. The next thing is increased free radical production. Well, what's a free radical? A free radical, they're molecules with unpaired electrons. And what they want to do is they want to steal electrons from all the surrounding cells. And what they do is when they steal the other electrons from other cells, the other cells they can die, have DNA damage, protein damage. The two main ones you probably heard of, the reactive oxygen species and reactive nitrogen species, and they both damage the cells. We've probably heard, right, certain things have like quote unquote like antioxidant effects, and that's what they do. There are certain substances that can help the body fight and fix and get rid of reactive oxygen species. And the body actually has their own ways of fighting the reactive oxygen species. However, when this type of trauma happens, there's too much reactive oxygen species, it overwhelms the body's protective systems. And lastly is mitochondrial dysfunction. We probably all remember this from biology, mitochondria. It's a little organelle in cells where oxidative phosphorylation takes place. And remember, oxidative phosphorylation is where we use oxygen to make ATP, right? To take the glucose molecule and it turns into ATP. So you go through glycolysis, you get the pyruvate, and then pyruvate goes through the Krebs cycle or the TCA cycle, and you make a lot of ATP. And that's what cells need to live. When you have increased calcium, mitochondria does not work that well. But why am I telling you all that? Well, first of all, there's two types of injuries to brain. First is primary injury, shear force, stretching, direct trauma to neurons, as illustrated in the first picture. And then there's secondary injury. What is that? Well, there's hypoxia, hypotension, cerebral edema, blood-brain barrier damage, mitochondrial damage, all the reactive oxygen species causing oxidative damage. Something else important to note is called the Monroe-Kelly doctrine. This is it makes sense really, but it's saying, hey, look, the brain is in a enclosed space that does not expand, called the skull. And the substance of the brain should not be compressed because it causes damage to the brain. Therefore, there needs to be a constant volume of blood and CSF in that space, in the skull. So it's the brain, cerebrospinal fluid, and blood. You can't have too much blood or too much CSF in the brain, in the skull, sorry, because if that happens, it's going to push on the brain. So the body has a very, it runs a tight ship up there. But as you saw in the first three cases, those pictures, you have a traumatic brain injury, you break some blood vessels, what's going to happen? You're going to have extra blood. Where's the extra blood going to go? Nowhere. It's going to push on the brain. Where's the brain going to go? As you can see in the picture, you can have herniation, the brain gets pushed down where your spinal cord is. So how do we prevent this? Well, as healthcare providers, we would all love to prevent injuries, right? All the injuries. We'd be out of a job, but it'd be nice to make sure there's no injuries happen to our patients. But primary head injury, unfortunately, is not going to always be unavoidable. However, we can decrease or sometimes even prevent secondary injury. So EMS providers and first responders are the first line of defense against secondary injury. Very important. Pre-hospital assessment management. Well, like, how do we assess any trauma patient, right? A, B, C, D, E. Airway, breathing, circulation, disability, and exposure. So what are our goals of pre-hospital TBI management? Optimize oxygen delivery to the brain and load and go to a place where the patient can receive definitive treatment. How do we optimize oxygen delivery to the brain? Get oxygen to the lungs. Make sure the oxygen goes into blood. We got to get the blood to the brain. So based on the Brain Trauma Foundation guidelines for pre-hospital management and assessment of TBIs, this is what they say. Patients are closely monitored for hypoxia, hypotension, hypertension, hyperventilation, and hyper or hypothermia. Also throw in some optimal pediatric specific blood pressures. Very young infants, 28 days and younger, systolic over 70 is the goal. 1 to 12 months, systolic over 84. 1 to 5 years, systolic over 90. 6 to 18 years, over 100. And the optimal SBPs for adults is 110. We'll touch on that later as to why that is. So pre-hospital assessment and management, again, so how do we monitor these things? hypoxia, blood pressure, appropriate ventilation, right? Kind of a silly question, but we got SpO2 monitors for hypoxia, blood pressure, make sure we have appropriately sized blood pressure cuffs, appropriate ventilation. In tidal CO2 monitoring, the goal for values between 35 and 45, especially in patients with altered level of consciousness, and temperature. We don't want them too hot or too cold, especially in the PNW. They probably run more cold than hot. So make sure we have heat packs, blankets, and of course, in the summer, if we find some stranded hiker who's been out and lost, then cool them down if we can with ice packs. So going back to the airway breathing, right? A, B, C, D, E. So hypoxia occurs very frequently in TBI patients. In San Diego the San Diego County Trauma Registry, they evaluated 3,500 patients with moderate to severe TBI and they found that hypoxemia was associated with decreased survival. And a 2019 South Korean study looked at over 6,000 patients with traumatic brain injuries. And they found that the mortality and disability rates were 50% and 70% in patients with severe hypoxia, which is defined as less than 90%, 31% mortality and 47% disability in patients with mild hypoxia, which is defined as 90 to 94%, and 18.5 to 27.5 in normal oxia, which is an SpO2 over 94%. And that's quite a bit of a jump, right? They also confirmed what people probably suspect is that in shock status, when a patient's hypotensive and also hypoxic, there's a 47% mortality and 57% disability, and a 20% mortality and 31% disability in non-shock status. So how do we deliver oxygen to lungs? Well, you can measure the SpO2, right, first with a pulse oximeter, and then we can use various things to deliver oxygen to the lungs. If the patient's spontaneously breathing, they can use nasal cannula, oxygen masks. If they're not spontaneously breathing, we have bag valve masks and advanced airways. We got a King airway and an ET tube. I've seen both being used on our trauma patients. And the goal of SpO2 is 90%. That is what the Brain Trauma Foundation guidelines say. But after reviewing that South Korean study, I'm inclined to say make it even a little bit higher. Hypotension, circulation, move on to circulation now. So a 2024 meta-analysis found that over 400,000 TBI patients, hypotension, which is defined as an SBP between 90 to 100, causes a twofold increase in odds of mortality in patients with TBI. A single hypotensive episode can cause a twofold increase in mortality in patients with prolonged hypotension can reach mortality rates over 50%. Dr. Eric Lay, out of, I think he was at Cedars at that time, in 2012, looked at 15,733 patients in LA County with moderate and severe TBI. And with regards to mortality, they found that the threshold for hypotension was 110 for ages 15 to 49, 100 for ages 50 to 69, and 110 for ages over 70. This is a very important study, a pretty landmark study, because up to this point, the trauma community has considered SBP under 90 to 100 as what we said was hypotensive. But now, looking at TBI patients, this is what they found, is that it should be actually higher. So piggybacking off of that, in 2020, they looked at the TQIP data, and what TQIP is, a Trauma Quality Improvement Project. It is a huge database. The whole, it's used by hundreds of hospitals across the entire United States, and we put in patient data points, like for a lot of different types of injuries. And the goal of it is to have a big database for us to look at the data, have a higher number of patients to see if there's anything we can do to be better, right? But also look for trends and maybe change some of the dogma that we have assumed to be true. And what they looked at was looking at 154,000 patients, right? So look at the TQIP has 10 times more than the patients in LA County. Look at these patients with TBI, and they found that the risk of mortality decreased with increasing systolic blood pressure, and it plateaus at about 110 for patients of all ages over 18, which is probably why for a lot of our trauma activation criterias, right, 110 systolic blood pressure is a cutoff for full trauma. All right, well, how do we measure the blood pressure? There's a blood pressure cuff. We all know how to use that, and also palpation. If you can palpate a radial pulse, I think what that's an SPP of at least 80 to 90, right? Optimize cerebral perfusion. Well, we always say, right, get 2 large bore IVs if we can for a rapid fluid delivery. If they're hypotensive, do we just watch them? No, we give them fluids. We give them normal saline. And we want to prevent intracranial hypertension. How do we do that? If we can, put the head of bed over 30 degrees, but in these polytrauma, multi-system trauma patients, if you suspect, back fracture based on mechanism, probably don't sit them up. Um, can't really do that. And avoid hypertension as well if you can. You don't want their blood pressure to go over 160 millimeters of mercury if you can help it. And we'll talk about that. So is that it? Just deliver oxygen to the brain? No, actually, just a little bit more nuanced than that. So now I want to kind of talk to you guys about cerebral blood flow. So blood gets to the brain through 4 major blood vessels. There's 2 big ones in the front. They're called the carotid arteries, and there's 2 smaller ones in the back. They're called the vertebral arteries. And the pressure that goes to the brain is called the cerebral perfusion pressure. What that is that is the difference between the mean arterial pressure and the intracranial pressure. If the intracranial pressure goes up and your mean arterial pressure stays the same, then you will have a decrease in cerebral perfusion pressure. That's important to know because if you have a decrease in cerebral perfusion pressure, you get less blood to the brain. And remember, the brain loves oxygen and glucose. So if there's not enough blood carrying oxygen and glucose to the brain, then our brain's not going to be happy, and therefore worsening the secondary injuries. The brain also prefers to have a very continuous flow of blood and oxygen as well. And this is achieved by having a very complex regulatory system. Well, why? Because our blood pressure, as you know, doesn't just sit like at 130 over 70 all day. If I'm going out for a run, it goes up, right? If I'm sleeping, hopefully it goes down a little bit. A lot of our other organs in our body, they see what the amount of blood they see is kind of based on our blood pressure. When my blood pressure goes up, my kidneys probably sees a little bit more blood, gets a bit faster. If I'm sleeping, right, my blood pressure goes down maybe to 100, then my kidneys probably won't see as much blood that fast. But the brain doesn't like that. So what the brain does is it really regulates, it kind of keeps constant the amount of blood flow to the brain. This chart that I'm showing you, the y-axis, the up and down line, that's measuring your cerebral blood flow. And then the x-axis on the bottom is the blood pressure. So see that red line right here. The red line kind of shows you the amount of cerebral blood flow with a relation to the mean arterial pressure. So look at right here. So it's about 60. So from about 60 to 160, the brain gets a steady state of blood flow. If you go down, if your blood pressure drops, then you get less cerebral blood flow. Looking over here is PaCO2. As PaCO2 goes down, the brain also gets a little bit less blood flow. But when patients have chronic hypertension or patients with a severe traumatic brain injury, that red line right here, it actually shifts to the right. Well, what does that mean by shifting to the right? Why is that bad? Well, here's 60. Let's say this is 80 right here, right? So when the brain's normal, non-injured blood pressure of 80, there's still a good constant state of blood flow that we want, right? But when they're bad traumatic brain injury, even a blood pressure of 80, as you can see, decreases the cerebral blood flow. Also, changes in pH and PCO2 can affect how much can affect the autoregulation of the blood of the brain as well. So one thing we said was hypertension, right? So we don't want it to go over 160 for patients. Well, why? So I forgot what year this was, but they looked at 300,000 TBI patients from the National Trauma Data Bank and found the odds of mortality was 1.33 for patients with pre-hospital blood pressures of 160 to 180 and 1.97 for SBPs of 190 to 230. So definitely having pre-hospital hypertension increases the odds for mortality. And they attribute this to the release of catecholamines like epinephrine in our body, injury to the blood-brain barrier, causing increase in cerebral edema and increases in intracranial pressure. Because remember, if all these small blood vessels are injured, the body's trying to clot all the small blood vessels, the capillaries that are injured. Now, is it easier to clot when there's a lot of, low pressure going to it, or at least normal pressure going to it? Or is it easier to clot, or is it harder to clot with like a blood pressure of 200, right? Of course, it's going to be easier to clot when the blood pressure is not 200. There's less high-speed flow through that. What about hypercapnia and hypocapnia? Well, here's what they do. Hypercapnia, it causes vasodilation in the brain, increasing cerebral blood volume, and potentially raising intracranial pressure. Hypercapnia, right? That means your PCO2 is over 45. Hypocapnia, PCO2 less than 35, it causes cerebral vasoconstriction and potentially decreasing cerebral blood flow. When I was going through EMS training in 2024, I remember they were saying, "Hey, if you think a patient has a TBI, hyperventilate them, get their PCO2 like less than 30." And the goal was to cause some cerebral vasoconstriction to decrease the blood, the bleeding in the brain. However, they found that that's actually bad. You actually want, sometimes we overdo it and we want the brain to get blood and oxygen. So now the goal is keeping the patient normocapnic. What about temperature? Hypothermia. Is that good or bad? Well, in theory, it can decrease intracranial hypertension. But there was a study that came out in the last, I think, 5 to 10 years. They actually looked at that. They looked at hypothermia in patients with TBI, and they found that it does not improve survival or outcome. As a matter of fact, hypothermia is part of the lethal triad of death of acidosis, hypothermia, coagulopathy that kills patients. So right now, the recommendation is to keep the patient as normothermic as possible. All right, moving on, kind of disability. Glasgow Coma Scale. It was one of the most widely used clinical measure of consciousness following TBI. It was created in 1974. And looks at three things: eye opening, verbal response, motor response. For peds, it's a little bit different because they can't talk. Not all of them can talk to you and follow commands. And the motor response, right? It's got the most points. It's got 6 points, as opposed to verbal or eye opening, which has 5 points and 4 points each. So the motor response carries the most similar level of prognostic information as compared to the complete score. As a matter of fact, there's entities out there coming up with motor-only scoring systems, like the simplified motor score. Uh, it is easy. It's 0, 1, or 2. And they found that it's almost as good as a complete GCS. And some hospital institutions only look at motor for certain trauma activations or upgrading them and stuff. And these, for the pre-hospital setting, we should get a GCS at least once every 30 minutes or a change in mental status. Should be obtained before patients receive any sedatives, paralytics, and even narcotics. And definitely should be part of the communication and handoff to the receiving hospital. Let's also talk about TXA or tranexamic acid. It's been around since 1962. What does it do? Well, it's an antifibrinolytic medication. What does that mean? It just means it prevents the breakdown of the clots. So, when we have when we have an injury to our blood vessels, the body clot, forms a big clot. It's a big coagulation cascade, platelets, clotting factors. But we can't have a clot there forever, right? So the body actually has an automated once you form the clot, it wants to break it down. And TXA is a medication that prevents the breakdown of the clot, the natural breakdown of the clot. It was created in Japan by a husband and wife, uh, physician scientists, who initially found a drug called aminocapric acid, and they were trying to use it to stop hemorrhage in postpartum patients. Then a few years later, they removed like a lysine group or something, and then it's TXA, and it works even better than the aminocapric acid. And so it's been used in Japan for decades and decades, but it's only, I think, in the last 20 or 30 years that we in the Western world and Europe started using it a little bit more and more. The big studies have been done on the Crash 1, Crash 2, and Crash 3 trials. The most recent one is a Crash 3 trial. It's a European study, multi-centered, randomized, placebo-controlled trial, showing that looking at patients with isolated TBI were randomized to be given 1 gram of TXA within 3 hours of injury. And what they found was that for all TBIs, there was no significant 28-day mortality difference. But for mild to moderate TBIs, which is the GCS of 9 to 15, they did find a clinically significant difference in the survival. They didn't specify whether it was given, there was like, I don't think it was given pre-hospital. I believe it was given in the hospital. And all these patients did have intracranial hemorrhages seen on CT, or their GCS was less than 12. That's when the patients got it. I think in 2020, Susan Rao, she was it's not OHSU anymore, but I trained with her at OHSU. She performed a study. I don't know if the study was going on when I was there, but what they did was they looked at pre-hospital administration of TXA versus placebo on functional outcomes in patients with moderate to severe TBI within 2 hours of injury. They based on a GCS of 3 to 12. So the patients were either given 1 gram TXA bolus followed by 1 gram TXA infusion over 8 hours, a 2 gram bolus followed by 1 gram of placebo infusion, or placebo bolus and placebo infusion. What they found was that there was no significant improvement in 6-month neurologic outcome via the Glasgow Outcome Scale Extended, or the GOES score. But the thing with that study is that 56% of the patients actually had bleeding on the brain, or intracranial hemorrhage. So 44% of patients that they were given the drug to did not actually have any intracranial hemorrhage. So what they did was 4 years later, they looked at the subset analysis of the patients who received the different dosages and found that patients who received a 2 gram TXA bolus had a significantly lower 28-day mortality than the other two groups, which is the 1 gram infusion, the 1 gram bolus followed by a 1 gram infusion versus the placebo. There was still no significant difference in neurologic outcomes, however. So should we give it? Well, sounds pretty good, but remember, drugs do have side effects, and some of the side effects of TXA, at least, I mean, aside from thromboembolic events, that in the study is seizures. I think it occurred in also like 3 to 5% of all the patients that received it. I mean, there's a pretty small risk, but just remember that every time we give a medication, there are always going to be side effects. So if we do give it in the field, it's important to communicate that to the hospital staff as well, so we don't give them any extra. Okay, so let's do a quick review for pre-hospital management of TBI patients. So what do? We monitor and treatment goals. What are they again? Make sure we have an adequate airway, Hypoxia should be avoided. Goal SaO2 is 90 over 90%, but I want to say if you can get it higher, you should. Make sure the blood pressure's higher than 110 and less than 160 if you can by giving them fluids. And if they're intubated and they're very hypertensive, you can give sedation as well. Make sure they're normal capnic. Remember that the optimal end-tidal CO2 is 32 to 45 millimeters of mercury and avoid hyperventilation. Make sure they're normal thermic, not too hot, not too cold. Get a GCS every 30 minutes, and when there's a change in mental status, assess the pupils, and avoid hypertonic saline in a pre-hospital setting. I didn't really get to touch on this, but hypertonic saline or like mannitol and whatnot, those are something we give can be given to patients to decrease the intracranial pressure. So they have done studies where we have given, where they looked at EMS agencies or pre-hospital administration of hypertonic saline, and there's been found that there's really no difference in mortality benefit or outcome benefit. And the problem with those is, hypertonic saline, what does that mean? Well, anything that's more salty than 0.9%, right, which is normal saline. So some people use 3%, some use 20%, some use 7.5%. So there's really no standardization between all these. So for now, the Brain Trauma Foundation recommends to not give hypertonic saline or osmotic diuretics like mannitol in the pre-hospital setting. Pre-hospital TXA administration is left up to the various healthcare systems. Let's go back to our cases again. Here's the first case. There's a review. 32-year-old female fell in jail. GCS was 13, pretty good, right? Patient didn't have end-tidal CO2 recorded at that time, but when when she arrived at the ED, became unresponsive, postured, blown pupil, intubated, taken to the CT scanner. There's a left subdural hemorrhage with midline shift again. And they called Life Flight and transported the patient to Peace Health. Initially at the hospital, she was given TXA and hypertonic saline. Her pupils were uneven during transport, and end-tidal CO2 during the air transport was 31 and 41, between 31 and 41. She was taken to the OR for an emergent craniectomy, hematoma evacuation, and drain placement. And you can see on the CT, it looks a lot better, right? The blood is pretty much gone. Over here, a little bit of air. That black is air on CT scan. That's because they opened this skull up and some air got in there. That's not a big deal. But as you can see, the brain is almost back to midline right here. Patient progressed pretty well and was eventually discharged to an adult family home. Second case, here's a 50-year-old male who fell off a ladder, really hypertensive on scene, right? He was seizing, hypertensive, low GCS, end-tidal CO2 was pretty low. This guy was probably hyperventilating by himself, like auto hyperventilating to drop his PCO2. So he was appropriately intubated, and the repeat end-tidal CO2 was 35, which is good. His blood pressure was definitely high, right? 193. Y'all gave him fentanyl, Versed, blood pressure back down to 160, and it stayed about that during the entire transport. When he arrived in the hospital, GCS was 6. Here's the skull fracture, epidural hematoma on the back, subarachnoid hemorrhage in the back and in the front. Definitely looks like some intracranial hypertension. He was given TXA and Keppra. He was admitted to the ICU. But the one thing is that with that skull fracture, it actually probably gave his brain a little bit room to swell. So he did not actually get any surgical intervention at that time. His repeat CTs were stable, stayed in the ICU with some neurologic recovery. He was able to follow commands and use his left upper and lower extremities. Patient underwent tracheostomy and a surgical gastric feeding tube placement, and he was discharged of Vibra for ventilator weaning. His gastric feeding tube was dislodged, unfortunately, at Vibra. And he developed septic shock, and he had to go get a laparotomy, which means you have to cut the patient's abdomen open to remove the gastrostomy tube. They placed a different type of feeding tube. And he was weaned completely from the ventilator 1 month after injury. And he went to inpatient rehab at the time of discharge and was able to use both arms pretty well and his left leg. Last case, this is the patient who was ejected and found 60 feet away from the car. Let's look at her blood pressure. Pretty good. 132/71, pulse 80, SpO2 100% on oxygen mask. But based on low GCS, vomiting, she was very appropriately intubated on scene for airway protection. End-tidal CO2 was 41. That's pretty good. Pupils around equal. Arrived in ED. Vitals are stable. Taken a CAT scan. What kind of bleed is this again? Subdural with a midline shift. So she was taken to the to the OR for craniectomy emergently. As you can see, there's a missing piece of the skull right here. And the blood is pretty much gone. And the brain is now more midline. Here's the ventricles I was talking about earlier, the little butterfly-shaped things. They're more back in the middle. She woke up the next day and was following commands and extubated. They took the breathing tube out, discharged home 6 days later. And a few months later, she had her skull flap or bone flap replaced right here. Any questions?
Dr. Wang, that was great and really helpful. I really appreciate it. Can you talk about how you think about managing blood pressure in a patient that has both a head injury and hemorrhagic shock?
Sure. Yeah. For those patients, we would prefer to see them with an SBP. I would say at least 100 still. Are you kind of touching on how for certain patients with hemorrhagic shock, we want to, maybe have like permissive hypotension kind of thing, or
Exactly. Yeah.
yeah. So the thing is, my belief is I can stop bleeding. I can fix those things a lot easier than I can fix a dead brain or a malperfused brain. So many times, like, it's a good thing because there are many instances, right, where we have a patient, let's say, was in a motorcycle crash where they have a traumatic brain injury, like a mild or moderate, but they also have a grade 4 spleen laceration. And there's a grade 4 spleen laceration is pretty bad. Now, nowadays, a grade 4, we don't necessarily take them to the operating room for a laparotomy. What we would do is we would watch these patients for any hypotension. What they have, if they get hypotensive, we could give them blood products, try to resuscitate them, get their blood pressures higher. And if they drop again, the blood pressure drops again, we call the radiologist, they take them to the IR suite, and we can try to plug up the splenic artery. But sometimes the problem is if a patient has a pretty, like a moderate severe traumatic brain injury, we just don't hesitate because remember what I said. If you have, oh, sorry, we don't hesitate to take the patient to the OR sometimes for a splenectomy because remember what I said, even a single episode of hypotension increases the risk of mortality and morbidity. So there are times where if a patient has really bad traumatic brain injury, but also has like a grade 4 spleen injury, I have taken patients like this to the operating room and just removed their spleen so I can prevent any hypotension. Did that kind of answer the question?
Yeah. No, that's really helpful. I mean, so what you're saying is prioritize the brain. Like,
Mm-hmm.
oh, that's
Yes,
helpful.
sir.
Thanks.
Because yeah, I think a patient missing a spleen is a lot better than a patient being comatose with a spleen. Any other questions? Right. Well, thank you guys all for your hard work and dedication. And remember, y'all are the patient's first line of defense against secondary injuries. Um, And you probably I've probably seen a lot of you guys around at Southwest. If you guys see me around, feel free to say hi. Have any questions, hunt us down, ask us. If there's any other ways you guys think we can get more involved in either training, give talks or whatnot, like this or anything else, just please let us know. We'd be happy to and be honored to get more involved in any way that we can.
Yeah, so I just second that. We're, Peace Health just went through its trauma accreditation, and I'm just, as an EMS medical director, I'm just really struck at how lucky we are to have such an engaged and dynamic trauma team, great partners with EMS. The remainder of the trauma education and PCEP for this year is going to be delivered by trauma specialists from Peace Health. Dr. Wang has also really leaned into EMS, and he's vice chair of the Regional Quality Improvement Committee. Um, I'm just going to make two comments, just reminders about protocol updates that have bearing on traumatic brain injury. Remember that when we intubate patients with traumatic brain injury, this is part of the reason that we have such a focus on airway one, avoiding hypoxia and hypotension for brain injured patients is critical, as Dr. Wang outlined, in having the vital signs 3 minutes prior to intubation and within 5 minutes after intubation is critical for demonstrating the good care that we do. And then just as a reminder that in head injured patients, when we need that neuro exam, we preferentially paralyze with succinylcholine choline over rocuronium. But that's all I have, and mostly just deep gratitude for the teaching and the partnership.
Well, thanks again, everybody. It's been a pleasure. Mhm.
Thank you. And then Mark, would you be willing to put up the link for feedback, please?
Yep, absolutely. Thanks again, Dr. Wang. Really appreciate your time and efforts with this.
Oh yeah, no, my pleasure. Thank you guys for the invite.
Just put up the QR code for feedback. And again, we really appreciate any input. We want to make this education the best possible.